Hello, good morning, everyone, and thank you, the organizing committee, for giving me this opportunity to talk. So I'll be presenting on the comparison of SBRT and RFA for early stage non-small cell lung cancer. So this is the paper which was published in the Annals of Translational Medicine in 2022. The comparison of SBRT and radiofrequency ablation for early stage non-small cell lung cancer, a systematic review and meta-analysis. I would say that my disclaimer is I am a radiation oncologist, so please bear with me if I am biased towards the SBRT, but I will like to present the facts presented in this article. So the introduction of early stage non-small cell lung cancer, the surgery with systematic mediastinal lymph node dissection is the standard of care for operable early stage non-small cell lung cancer, and SBRT is an equal and effective alternative for operable non-small cell lung cancer for those patients who are unwilling for surgery. And SBRT is the standard of care for inoperable early stage non-small cell lung cancer as far as the various guidelines have been reported. So in this study, in this meta-analysis, they included the studies from 2001 to 2020, so which is a very long period, and they searched the PubMed, Medline, the Embase, and the Cochrane library for all the studies. They included only the original English language study, and they reported local control rate, overall survival, and adverse event, and they calculated the pooled analysis from that. So the eligibility criteria, the original English studies only were included. Stage 1 non-small cell lung cancer, those patients who were unsuitable for surgery, and clinical outcomes were reported as far as the local control, overall survival is concerned. The exclusion criteria, they excluded the case report, comments, editorial, and review. They also excluded the studies with less than 15 patients in the SBRT or less than 5 patients in the RFA studies. SBRT with fraction number more than 8 were excluded, and fraction dose less than 8 gray has been excluded. So they excluded the ultracentral tumor, I guess. And the other treatment, including surgery, chemotherapy, radiation therapy, and immunotherapy combination, have also been excluded. So the data extraction was done by the 2 independent reviewers, and they search according to the first author's name, publication year, country, study design, and the percentage of male, stage, and follow-up period. As far as the SBRT studies are concerned, they have a search according to the radiotherapy regimen, total dose, the dose per fraction, number of fraction, and biologically effective dose. They reported local control and overall survival, where it was reported as 1 year, 2 year, 3 year, and 5 year. The local control rate was calculated based on the freedom from local progression, and the survival outcomes were extracted from the Kaplan-Meier survival curve in all the studies. They also reported common and grade 3 to 5 event as per the CTC. So statistical analysis, they have reported both the random effect model and the fixed effect model for the pooled analysis. The I-square statistic was used to measure the degree of heterogeneity between the studies. The SPSS and R software was used. The meta-analysis was reported using the R package meta. The funnel plots were constructed within the funnel function to estimate the publication bias, and two-sided p-value of less than 0.05. It represents the level of statistical significance. The result, they almost included 2090 record, and out of all the exclusion criteria, only 105 studies included in this meta-analysis, of which the 87 were of the SBRT, and RFA only 18 studies. And the patient population was approximately 12,800 in the SBRT versus only 1,500 in the RFA arm. So now there was no publication bias after trim and fall analysis in both the SBRT and the RFA. As far as the local control rate is concerned, I'm only showing you the 5-year local control because it is more or less the same in 1 year, 2 year, 3 year. The 5-year local control rate, as you can see, the fixed effect model and the random effect model, the heterogeneity is very high. But the 5-year local control is more or less approximately 90% in the SBRT cohort, and the 5-year local control of RFA was included only in 3 studies. So the number of patients in the RFA arm was very less at the rate of 5 year, and the local control rate was approximately 40%. If you see the pooled analysis for local control rate, it was statistically significant in favor of SBRT as compared to RFA. If you see the 5 year, the local control rate was approximately 90% in the SBRT arm versus 40% in the RFA arm. As far as the 5-year overall survival is concerned, the 5-year overall survival is approximately 40% in the SBRT study versus 20% in the RFA arm or in the RFA studies. And if you see the overall survival, in the 1 year and 2 year overall survival, there was no statistically significant difference between the SBRT and RFA. But if you see the 3 year and 5 year overall survival, the SBRT has a higher overall survival as compared to the RFA studies, approximately 40% versus the 20%. As far as the adverse event is concerned, so majority of the studies in the SBRT arm has reported the radiation-induced pneumonitis. They have not reported the grade of the radiation-induced pneumonitis, so it may be grade 1 to grade 3 or more than that, but it was 9.1% in the SBRT, and the esophagitis only 0.2% because they have excluded the ultracentral tumor, and the rib fracture was 4%. In the RFA arm, the most common complication was pneumothorax. The rate was seen in 27%, pleural effusion 4%, and hemoptysis in 2.2%. So I did the literature review as per this trial, as per this meta-analysis, and there were 2 more published, so meta-analysis and systematic review, both in the 2010 and 2012 by Bilal and B et al. And both of them have shown that the SBRT is associated with a higher 5-year overall survival. As far as the local control is concerned, the SBRT was also favored. And in the other meta-analysis by B et al., they reported that the local control or the local failure rate in the RFA arm was very high as compared to SBRT. So the strength and the limitation of this particular meta-analysis was, the strength is that they have included approximately 14,000 patients, but the limitation is that the studies were evolved from 2001 to 2020, and both the technique, RFA and SBRT, has evolved from the time of 2001 to 2020, and nowadays the SBRT and the immunotherapy can modulate the immune function. As we know, both the innate and the adaptive immunity can be modulated by the SBRT. So with this, I would like to thank the organizers.